Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on Auvelity, Dextromethorphan, bupropion, a combination medication. It's a relatively new medication. It was approved by the FDA for the treatment of Major Depressive Disorder in August of 2022. It's still brand name only, and I've not used it much, but I had a viewer who requested a video, and so I thought I would polish one off real quick. Auvelity has the distinction of being the first and only oral Nmda receptor antagonist approved for major depressive disorder. Nmda stands for N-methyl-D-aspartate, which is an amino acid derivative that's not technically considered a neurotransmitter itself, but it is an agonist at Nmda receptors, which are ion channels that bind to glutamate. So they're also glutamate receptors. And glutamate is the main excitatory neurotransmitter in the central nervous system. There are excitatory neurotransmitters and inhibitory neurotransmitters, and glutamate is the main one that is excitatory. And so NMDA activates NMDA receptors, glutamate receptors, preparing them to be stimulated by glutamate itself. These receptors are involved in memory and learning through a process that's called synaptic plasticity. And specifically, this involves an increase in the density of dendritic spines. So just to give a quick crash course in neuroanatomy, a neuron consists of a cell body, the soma, dendritic connections which receive information from other neurons, an axon terminal buttons, and then the synapse, which is the gap between neurons where neurotransmitters are released and where communication takes place. So the dendrites receive information. And you can imagine a tree-like formation where the dendrites are like branches of a tree receiving information. And so medications that block NMDA receptors can be implicated in this process of neuroplasticity, of increasing the number of those spines and thereby improving communication between neurons in the central nervous system, because now you have more receiving branches. And so when a neurotransmitter like serotonin is released from one neuron, then it has a greater chance of stimulating serotonin receptors on the postsynaptic neuron because you have more of these dendrites. The stimulation of glutamate receptors by glutamate stimulates the growth of these nerve endings. That's the important thing. And this is thought to be the basis of learning and memory formation. However, you can also have a condition where you get overstimulation of these receptors, and that's been implicated in a process known as excitotoxicity, a process that's been implicated in the pathophysiology of a number of neurodegenerative conditions, including Alzheimer's disease, Parkinson's disease, vascular dementia, ALS, amyotrophic lateral sclerosis, and epilepsy. And so NMDA antagonists have been studied in these conditions, and Nmda, is an NMDA receptor antagonist that was approved by the FDA to treat moderate to severe dementia related to Alzheimer's disease. So Auvelity is not the first NMDA receptor antagonist to be approved by the FDA, but it is the first one to be approved for the treatment of major depression. NMDA receptor antagonists like dextromethorphan, and yes, that is the dextromethorphan, the DM in Wellbutrin-DM, the cough suppressant that is available over the counter, are a class of drugs that work to antagonize or inhibit the action of that receptor. And Auvelity is the first one approved for major depression. It also is the first oral antidepressant, period, approved with statistically significant improvement in depressive symptoms compared to placebo starting as early as week 1. Now, there have been other antidepressants that anecdotally have been noted to work quickly, and specifically the SNRIs, like venlafaxine, Effexor, and Pristiq. And clinicians have noticed that in those patients who need them, not just patients who would benefit from treatment with those medications, but patients with endogenous depression or major anxiety syndromes, patients that have a problem with their neurotransmitters. And we don't know the exact pathophysiology, but those patients with endogenous illness, with a genetic, in most cases, aberration that causes them to have symptoms of depression and anxiety, who have robust responses to medications, will often perk up and start to get significantly better in a few days. And we've seen that with the SNRIs anecdotally, but this is the first medication that has research data to back that claim. However, many patients may still take 6 weeks or longer for full recovery and particularly remission. In a 6-week clinical trial comparing dextromethorphan bupropion to bupropion monotherapy, so Auvelity versus Wellbutrin, not surprisingly, response and remission rates were significantly greater with the combination treatment at every time point beginning at week 2. So there's evidence to show that Auvelity works faster, and then you get a better response with the combination than you do with bupropion by itself. Now, dextromethorphan by itself is not classified as an antidepressant, but because it is implicated in neuroplasticity, you do get improvement in depression and anxiety symptoms, so it can be considered an antidepressant. The problem is that dextromethorphan has a very short half-life. It's cleared by the body in just a few hours. However, the addition of bupropion is what stabilizes the mixture, and I'll talk about that in a second. But dextromethorphan is a non-selective, non-competitive Nmda receptor antagonist, but it's also a sigma-1 opiate receptor agonist. That's how it has its antitussive properties, how it suppresses the cough reflex, because it is basically an opioid. It agonizes opiate receptors, and it stimulates that opiate receptor subtype. Now, the clinical significance of the pharmacodynamic profile of dextromethorphan with regard to depressive and anxious syndromes is theoretical at best. But we do know that Nmda antagonism leads to downstream glutamate release and the consequent stimulation of other glutamate receptors, including AMPA receptors. And AMPA stands for this: alpha amino 3-hydroxy 5-methyl-4 isoxazole propionate. And those AMPA receptors are other types of glutamate receptors, which again are ion channels in the brain responsible for most fast excitatory synaptic transmission. So you've got excitatory neurotransmission and you've got inhibitory neurotransmission. And then with the excitatory arm, you have fast and slow transmission. And so the AMPA receptors are the ones that are most important for fast excitatory synaptic neurotransmission, which is essential for normal brain function, including and especially memory and cognitive functions, which makes sense. You would think that you would need the receptors that are responsible for the rapid neurotransmission, because you're having to take in information, process it, and then incorporate it into short-term memory. So it just makes intuitive sense. But theoretically, dextromethorphan may have antidepressant effects because the activation of AMPA receptors leads to certain chemical cascades and ultimately an increase in growth factors, including brain-derived neurotrophic factor, BDNF, which is a protein in the brain and spinal cord that helps nerve cells survive and function. And this all causes the expression of synaptic proteins that then leads to the increase in the density of dendritic spines, as previously discussed. The bottom line is you block the Nmda receptor, and after a long cascade of events, you do see neuroplasticity. And neuroplasticity is good for the mood, for depressive and anxious symptoms, but it's also good for cognition, for memory and learning. Dextromethorphan also has affinity for the serotonin transporter. It blocks the reuptake of serotonin, and so it's thought to modulate serotonin levels in this manner, similar to the SSRIs, similar to Prozac and such. As a matter of fact, combining dextromethorphan with other serotonergic agents like the MAOIs, the monoamine oxidase inhibitors, and certain tricyclic agents, especially imipramine and clomipramine, can cause a potentially fatal serotonin syndrome. So there is significant serotonergic activity when we're looking at dextromethorphan. Bupropion, on the other hand, known by the brand name Wellbutrin when it's by itself, or Zyban when it's being used to treat smoking cessation, has no significant serotonergic activity. It blocks the reuptake of norepinephrine and dopamine, similar to stimulants. So it is a more stimulating, activating antidepressant, treats a different subset of depressive symptoms, and is really not indicated for anxiety at all, as the serotonergic agents are, the SSRIs and the SNRIs and certain tricyclic agents. But with Wellbutrin, you don't have to worry about serotonin syndrome. It increases noradrenergic and dopaminergic neurotransmission, and this treats various symptoms of depression and also improves cognition. As a matter of fact, bupropion is used off-label for the treatment of ADD, attention deficit disorder. But in this context, in combination with dextromethorphan, it also increases the availability of dextromethorphan by inhibiting its metabolism via the cytochrome P450 2D6 liver enzyme. More on that in a bit. The usual dosing range is 90 milligrams of dextromethorphan and 210 milligrams of bupropion. It's supplied in extended release tablets at half that strength, 45 milligrams of dextromethorphan and 105 milligrams of bupropion. And the initial dose is once daily in the morning. The bupropion component can cause insomnia, so you have to take it in the morning, although somnolence is actually not an uncommon side effect with this combination. And then after 3 days, the general recommendation is to increase to 90 milligrams and 210 milligrams, the maximum dose, divided into 2 daily doses separated by at least 8 hours. So once in the morning and then 8 hours later, another dose. It can be taken with or without food, but the tablets shouldn't be broken or chewed, as that would alter the controlled release properties. You do need to monitor the patient's blood pressure at baseline, and then blood pressure needs to be monitored throughout treatment, especially at the beginning. Patients should monitor their blood pressure anyway, but especially with this medication, this is the same recommendation that we give to patients who take bupropion monotherapy. I tell all patients that I start on Wellbutrin that they need to monitor their blood pressure. And this is primarily because of the increase in norepinephrine peripherally, where it causes vasoconstriction. The arteries constrict, this increases peripheral vascular resistance, and that increases blood pressure. Norepinephrine also tends to increase the pulse and the strength of each ventricular contraction. Tachycardia, a rapid heartbeat, is a potential side effect. If you get too much of bupropion, you can actually have a panic attack as well. We have limited clinical experience with Auvelity in overdose, but we rarely see lethal overdoses of bupropion. Seizures is what we worry about mostly, but also there can be possible cardiac disturbances as well as hallucinations, both visual and auditory. I would be very loath to prescribe a patient with schizophrenia, for example, who may already be having prominent auditory hallucinations, bupropion for depression. And if I did choose it, I'd be very careful about the dose. Bupropion should be used with great caution, if at all, in patients already experiencing these perceptual disturbances. With dextromethorphan overdose, we see nausea, vomiting, and a stupor that can progress to coma, including respiratory depression. And this is most likely due to the opiate effect, the agonism of the sigma subtype of opiate receptors, because we know that opiates do cause sedation and they cause respiratory depression. But you can also see hyperexcitability with bupropion overdoses and seizures, as well as perceptual disturbances. As a matter of fact, when dextromethorphan is taken recreationally, it's taken in small overdoses intentionally. It's really big with adolescents, with teenagers, and they do it because it causes dissociation and it causes hallucinations. So with Auvelity and overdose, we would be most concerned with grand mal seizures and a toxic psychosis, meaning a medication-induced psychosis. Auvelity hasn't been evaluated for long-term use. It's a fairly new medication. It's only been on the market for a couple of years, but it's not habit-forming, and it doesn't have to be tapered when it is discontinued. Can it be abused? You bet. Formulations of bupropion have been abused by individuals who crush and then snort or inject them, those who prefer stimulants, whose drug of choice is a stimulating medication. And it could also be combined with opiates the way cocaine is combined with opiates, with heroin, for example. But over-the-counter dextromethorphan, as I've mentioned, in large doses is abused, especially by adolescents, for its hallucinogenic dissociative effects. The over-the-counter medication that is most famously abused goes by the brand name of Chlorcidin. And the cough and cold preparation, Triple C is what the kids call it, Chlorcidin cough and cold, has the highest concentration, 30 milligrams of dextromethorphan in each little red pill, which kids also call Skittles because it looks like the Skittle candy. And it really does actually resemble that. The red ones anyway, except instead of an S, they have 3 C's. Triple C. I remember the kids calling me Triple C in the emergency room when kids would come in. And you've got 30 milligrams there in each little pill, so it would be easy if you took 10 of them. That's 300 milligrams of dextromethorphan. And so that's going to cause an opiate-like stupor and perceptual disturbances and a lot of times dissociation. It would be hard to drink that much Robitussin. Dextromethorphan is the same ingredient as the DM in Wellbutrin-DM. It's a cough suppressant. And you can get it over the counter without a prescription. Other Nmda receptor antagonists include ketamine and nitrous oxide, anesthetics that also produce dissociation, and which are also abused as recreational substances. I actually used ketamine for a little while. I'm currently in remission from chemical dependency, and I remember using ketamine. I didn't like it. There was a fine line between the dissociation, just feeling a little bit of that, and actually having full-on dissociation, which can really cause anxiety in patients that are prone to it. I just didn't care for it. And I remember one effect that was very interesting. I couldn't tell sometimes where I ended and whatever it was I was touching began. So the boundary between my hand and the other object was difficult to distinguish. And it was very unsettling to not know what belongs to me and what belongs to the thing that I'm touching. But another Nmda receptor antagonist that is a drug of abuse is PCP, angel dust. And that's one that I never did use. Nmda receptor antagonists are commonly used as anesthetics for humans and animals. And the state of anesthesia that they induce is referred to as a dissociative anesthesia. Dissociation being a condition that includes perceptual disturbances, including hallucinations, but also a feeling of detachment, derealization, and/or depersonalization, which are dissociative symptoms in their own right. And they can be part of a psychotic syndrome, and they can also be reported sometimes in major mood disturbances, a feeling that things aren't real, or a feeling that you're outside your body, kind of floating above yourself, watching yourself. Both of those have been reported with Nmda receptor antagonists. Notable side effects. Somnolence is not uncommon. It's presumably due to the medication's central actions at the sigma and Nmda receptors. You can also see headaches and dizziness, which are caused at least in part by the actions of norepinephrine and dopamine in the brain. And norepinephrine also causes side effects vis-a-vis the actions in the periphery, including sympathetic actions, such as dry mouth by interfering with the actions of acetylcholine, as well as hyperhidrosis, excessive sweating during workouts and other forms of exertion. You can also commonly see diarrhea, and sexual dysfunction has also been reported. Weight gain is not seen. As a matter of fact, bupropion is one component of Contrave, an FDA-approved medicine for weight loss. And overall, bupropion, Wellbutrin XL, is a weight-neutral medication. Patients definitely don't gain weight on it when it's used for depression. Life-threatening or dangerous side effects are mainly related to increased blood pressure, and that can be very dangerous in patients who are susceptible to hypertensive crises, patients who are at risk for heart attacks and stroke, for example, who already have an elevated blood pressure or who have a significant degree of atherosclerosis, etc., patients with coagulopathies and that sort of thing, and patients with seizure disorders. Now, seizures are admittedly rare with this medication, particularly when we're not talking about overdose, when we're talking about just therapeutic doses. The risk is dose dependent, so it increases with escalating doses, and obviously in patients with predisposing factors. Rarely you can induce mania in those individuals who are likewise susceptible to that sort of thing, patients with bipolar spectrum disorders, for example. And rarely there is activation of suicidal ideations and behavior, but this is more a concern with children and adolescents, especially impulsive youth. Short-term studies did not demonstrate an increased risk of suicidality with antidepressants in general compared to placebo beyond the age of 24. And so the FDA black box warning that you see with all antidepressants, it's specific to individuals who are younger than 24. And it could very well be a paradoxical effect of the medication as you're getting it on board and you're not at steady state yet. So I don't discount it, but it's not something that I really worry about. Now, if I have somebody who's young and impulsive and who's attempted suicide a lot and serious attempts, then I'm very, very careful and I take the black box warning very seriously. But in most patients, it's really not a concern, particularly those patients who have never had trouble with their mood and who've never been suicidal, who've never even had the fleeting thought. Contraindications are again mainly related to this concern about seizures. So if a patient has poorly controlled epilepsy, for example, also, if a patient has a current or prior diagnosis of bulimia or anorexia nervosa, this is sort of a legacy contraindication, and it's a relative contraindication as far as I'm concerned. It's also based on, again, a concern about grand mal seizures, which were seen with high-dose immediate release bupropion in patients who had low body weight and who had active anorexia nervosa. But ever since then, we've been very cautious about patients with eating disorders and Wellbutrin. I will definitely use Wellbutrin, depending if they're not actively purging, so there's no reason to suspect an electrolyte disturbance, and they understand the risk, then I'm very careful with the dosing of it. I use extended release preparations, and I don't exceed 450 milligrams all at one time. I had a patient today who was elderly. She was in her 80s, and she has a fairly low body weight, 110 pounds. And so in this lady, I told her to take 300 milligrams in the morning, and then wait 2 hours and take another 150 milligrams of the extended release preparation. She has no history of eating disorders, but I'm concerned about seizures. If a patient is taking an MAO inhibitor, we worry about serotonin syndrome because of the dextromethorphan. And so an MAOI can't be started for at least 5 to 7 days after you discontinue Auvelity to allow for the complete washout of that medication. And Auvelity should not be prescribed for 10 to 14 days following the discontinuation of an MAOI, because MAOIs, monoamine oxidase inhibitors, irreversibly inhibit the monoamine oxidase enzyme. So even though the MAOI itself may be cleared from the body in just a few days, new MAO, monoamine oxidase enzyme, must be synthesized by the body to regain functionality of that method of clearing serotonin from the active sites. So there are different ways that serotonin gets cleared from the synapse where it has its action. Reuptake is one, and another is degradation by monoamine oxidase, by that enzyme. And then it also just diffuses away. Some of it just floats away. Some of those molecules just diffuse away. So that's another way. Otherwise, any serotonin molecules that are in that synapse are going to be stimulating postsynaptic receptors. And if you got too much of that, then you can get serotonin syndrome, which can be potentially fatal. And it's characterized by hyperthermia and delirium, muscular rigidity, possible seizures, and this could lead to death as well. If a patient is taking any other formulation of dextromethorphan or bupropion, it should not be combined with this medication. So if they're on Zyban for smoking cessation or they're already on Wellbutrin, then you shouldn't give it. Now, if I had a patient who was on Wellbutrin and I wanted to give them Auvelity, then I would just take into consideration what their total dose of Wellbutrin would be. Maybe I want them on a high dose of Wellbutrin for their depression. So I would factor in the fact that they're now taking Auvelity. You also want to use this medication cautiously with other drugs that increase the seizure risk: tricyclics, lithium, certain antipsychotics. Now, Depakote, Trileptal, Lamictal, and other anti-convulsant mood stabilizers would obviously be safe in this regard. But Auvelity should be used with caution in patients with bipolar disorder. Fall precautions are advisable due to dizziness and somnolence, and patients should be advised to be cautious operating hazardous machinery until they know how this medication is going to affect them. The pharmacokinetics is important for this medication, and it's what makes this combo drug unique. Food doesn't affect the absorption of this medication, and it is an extended release preparation. The mean elimination half-life is 22 hours for dextromethorphan and 15 hours for bupropion. Both are metabolized by the liver enzyme 2D6, the cytochrome P450 enzyme 2D6. But bupropion is an inhibitor of 2D6, thereby stalling its own elimination with repeat dosing, as well as, importantly, that of dextromethorphan. Dextromethorphan alone can have an elimination half-life as low as 2 to 4 hours. And that's why you have to keep redosing cough syrup for your cough. But when you add bupropion, it not only inhibits the reuptake of norepinephrine and dopamine to improve mood and cognition, but it serves to stabilize dextromethorphan so that dextromethorphan has time to hang around long enough to block enough Nmda receptors long enough that you have all of this downstream cascade where glutamate ultimately acts on AMPA receptors, and you ultimately get neuroplasticity, an increase in the dendritic spine concentration. And that's a positive effect on neuroplasticity, which is the believed mechanism of action. The main disadvantage of this medication, it's not available in generic form, so it's expensive, and you may have to get prior authorization from insurance companies before they'll pay for it. But a potential advantage would be that you could have rapid onset of action as early as week 1. And this combination is also being studied for the treatment of agitation associated with Alzheimer's dementia. So this medication has shown promise for treating depression in the elderly. So even patients without dementia. It's a medication that you would think about, and the main concern would be dizziness and fall risk in that population. Thank you for listening, and thanks to the viewer who requested Auvelity. I don't think I would have gotten around to reviewing it as soon as I did had it not been for that request. So it's an interesting medication, and it'll be interesting to see how it plays out as it's used in the long term. Thank you, and comments are always welcome.